So this is the chapter 7 in clinical toxicology, fourth year Form D, and we are dealing with alcohol intoxications, poisoning. So as we know, all we have mainly the two different formulations of the alcohol preparations. One is ethanol and methanol poison, methanol. So this class specifically talks about what all the clinical consequences that happens because of consumption of these two uh, uh, thing, and also we see the management, how to manage especially the toxic level of this ingestion of this ethanol and alcohol. So if we talk about the historical background, we have a very you can see that there is a historical background since almost 7000 BC. So the people were used to consume prepare the alcohol in different ways. They used to extract from the different sources and used to consume. Okay, so the alcohol has a very long history saying that consumption by the human being, so which usually used to relieve the stress or the euphoric effect that gives because of the alcohol. So that made the alcohol very widely used by the human being. But what happens is when they used to consume the alcohol because of its euphoric effect, people used to depend more on that and consume more of alcohol. And because of this, you can see that currently there is an very alarming figures where the harmful effects of alcohol. So could be because earlier it could be a beneficial. Even now there is some beneficial effect of alcohol when it is used in a very judicious manner. But more it is misused, okay, and dependence is caused. So you can see the statistics like 2.5 million deaths per year because of the alcohol harmful. You can also say that any scientific data say that avoid alcohol and smoking, so which is injurious to health. And the another part where the young age is more uh, damage is happened here. You can see like 3,20,000 young people between the age of 15 and 29 died from alcohol related causes. So it's also an alarming. See that 9% of all deaths in that age is because of the alcohol related. So it's also the reported by a WHO report like Global Status Report on Alcohol 2004. So this is the little bit background of how the alcohol causing and having an impact on the social and killing the people. So first we'll go to the ethanol intoxications. So we specifically talk about more on the acute ethanol intoxications. So there is a legal limit for intoxication is the 80 mg per deciliter. This is how the quantification of the alcohol is done. This and also there is an odor threshold of 10 parts per million. So you can see that especially in the traffic, during the traffic police testing, you can see that how we blow in the meter. They test for the any kind of the alcoholic content in the odor. So anything about 10 ppm, or also if blood concentration of the alcohol is more than 80 mg per deciliter, then we call it as it's an excessive consumption of alcohol. So even the legal system says that uh, it doesn't say that totally avoid the alcohol, but there should be an limitations which it should not cross, because after this limitations, the alcohol can show a lot of the side effects uh, because of that is. And if you say talk about how the pharmacokinetic parameters of alcohol, you can see that it's most commonly observed in the stomach and followed by duodenum and lastly by mouth and esophagus. And its distribution is also it's highly distributed for most of the tissues. You can see that volume of distribution is zero point 0.5 liter per kg, and it's also a half life is 2 to 6 hours. And most importantly, the metabolism of the ethanol goes on this pathway with combined with an NAD molecule and forms the acetaldehyde, and also with the NADH it causes acetate, which in turn acetyl CO, and lastly you can see that the whole alcohol is broken down and formed into carbon dioxide and water. So this is the end product of the alcohol. Whether it's a ethanol, whether it's a methanol, the end product is carbon dioxide and the water, which is the formations. And if you see the clearance is because it's a very potent vasodilator, uh, the clearance is very fast here, very rapid. You can see that 15 to 80 mg per 100 ml blood per hour is cleared. And also it's follow the zero order kinetics. So zero order kinetics in sense like independent of the concentrations, it kinetics the absorption, distribution, and eliminations take place. And they say like there are some quantity of alcohol which goes through lungs, urine, or sweat, but most are metabolized to acetaldehyde, especially in the liver. So this is a one primary thing why very chronic consumption of alcohol can leads to the um, liver injury. So it's something like consumption of more alcohol puts more work pressure on the hepatocytes, that the cells tissues that are there in the liver, and because of this they're unable to perform their work and becomes they die of the necrosis. So it puts more pressure. This is one of the most primary cause for the alcohol toxications. The blood levels are also expressed in milligrams or grams, as we have seen. So anything that 0.02 gram per dl can result of one typical drink, the quantifications. And this is the overall the different alcohol preparations, beverages that we usually use. So you can see from beer to the hard liquor, the alcohol content varies. So it just starts from 5%, maybe still less than this, few preparations. You can see the hard liquor around 40%. It may go around 42, 43%. And this is what the serving size is. You can say 12 ounce. Convert into the ml, it comes around 350 plus. And you can also see the hard liquor, the ounce is 1.5. The servings quantity are very less in the hard liquor. But if you see count the amount of alcohol that content, so you can see that 13.85 grams, the beer, and the hard liquor is 13.4 grams. So it's most of the, it's a misconception that many people say that just a beer is safe and does not contain more alcohol, because the quantity here is more, even though percentage of alcohol content is less, but because of quantity is more, you can, if you calculate the gram content of alcohol, it is almost coming to, you can see equal to the hard liquor thing. And coming to the pathophysiology, so the primary action of the alcohol is always most of the time is vasodilatation and also the depression. So they say like initial stimulations followed by depression. This is how for the most of the alcohol preparation, narcotic preparations, it usually acts on the cells and tissues. So it stimulates the GABA A receptor. As we know that GABA A is an inhibitory receptor. It usually, when you more stimulate an inhibitory receptors, the inhibit actions, that is reduce in any kind of nerve reflexes, or any kind of the behavioral or any other reactions can slow down. So this is how this is why there is more prominently seen in alcohol consumption cases. And also there is an increase in NAD ratio where the enzymatic reactions the increases, and also the ketogenesis. So the ketone body formation, you can see the complications in future slides. One of the ketoacidosis is one of the complication of alcohol intoxication. So the ketone body is formed because of decreased breathing rate. So it's a respiratory depressant. Alcohol is also a respiratory depressant where the oxidative metabolism reduces and anaerobic metabolism starts where the ketone bodies are formed. That's why there is increase in ketone bodies. And also there is a decrease in gluconeogenesis. Okay, that's why you can see that more of hyperglycemia cases in this. And also glycogenolysis is increases. So it's almost excuse me. So opposite to this gluconeogenesis and glycogenolysis. And always the fluid and electrolyte imbalance, you can see that there is a decrease in the sodium, potassium, magnesium. So very oftenly seen in the kind of the alcohol consumptions. So is everyone there following? Any questions?
Yes, yes, sir.
No questions, sir.
All clear.
Okay. Yes, Delvin. Delvin raised hand. Anything?
No, sir. No question, sir.
Okay. And you see the effect of blood alcohol levels in the absence of any tolerance. Okay, this is a quantified level of the alcohol in the blood. Okay, so you can see that how the increase in the quantity of alcohol can also increase the complications, its effects on the body. See, if you see that 0.02 gram per deciliter, the few effects that observed are just decrease in inhibitions and also slight feeling of any intoxications because concentration is very less. If you see that 0.08 gram per deciliter, so the complications, severity of complications increases here. See that cognitive functions decrease and also very complex. The thinking, thought, what he speaks, how he behaves, how you, what he takes the receptor from the other persons. Okay, will not be having coordinations. And also the motor performance. You can see the alcoholic persons, they are more of swinging, imbalance, and does not react to any quick reflexes. So that is observed. And also if you see the blood level of 0.20 gram per deciliter, there is also a slurred speech obvious, and also motor incoordinations, irritability and poor judgment. So this is all the more complicated things where because the one of the other complications problems that occurs because of this is most of the time the alcohol consumption is done outside. Okay, so somewhere in the out of the house or anything where there is no proper caretaker, and even if there is a caretaker, usually the more alcohol is there, they leave him and go off or anything. So when this at this stage the managing oneself, okay, at this thing it will be very very difficult. So that's how the complications it occurs. And also as I told, like the alcohol is so much uh, hazardous to health. So one is could be because of the more ingestion the body get more impacted and liver injury occurs and dies. And also the other important thing in the alcohol thing is in this alcohol consumptions is there a lot of uh, things that say that quarrels happens, fightings happens if it is in a group way, or even if some person's going on the way like he talks about to some other person, and for small issues there is also goes the murders, deaths, okay, because of the fighting. So that is the other one social impact that usually happens because of the severe alcohol consumptions. And next you can see that 0.30 gram per deciliter, that is a light coma where there is a subconscious level, and but still the person is alive. And also depressed vital signs. It's a very difficult situations where just before the death. And if any blood levels of alcohol goes above 0.40, so definitely it's lethal. So death can occur because of this. And this is the signs that immediately then there is a needed for medical attentions. So you can see that a lot of systems are involved. So especially the nervous system, depression occurs, sleepiness, coma, lethargy, and decreased response to pain. And also withdrawal accompanied by pain. So alcohol withdrawal effect also is one of the important thing that we have to consider. So I will just cover in the later versions of my presentations. Also digestive problems that include vomiting, bleeding, and dehydrations. Slower absent breathing. This is what I told about respiratory depression, where the oxygen level saturations will be decreased in the alcohol because of respiratory or slow or absent breathing. And the seizures, grand mal seizures, so quite often, delirium tremens, where there is no disorientations, and disturbances of visions, mental confusion, and muscular incoordination. And also disinterested behavior and loss of memory. And many times, people who have taken alcohol and done a lot of the havocs, okay, last day and next day the persons will not be even remembering of that. So loss of memory is also one of the thing during consumption of alcohol, and does not remember what he is doing and what actually it's going on. The This is what specifically we'll talk about some acute problems like alcoholic ketoacidosis, alcoholic hypoglycemia, fluid and electrolyte imbalance, and Wernicke's encephalopathy. This is one of the central nervous system problem. Also acute effects on heart, GI effects, alcoholic myopathy, trauma, and also any kind of associated with other substance poisoning. First, we'll see alcoholic ketoacidosis. As we've seen that one of the thing is increased in the ketogenesis. So there is a high Hanan gap acidosis. So H plus ions formation is very significant in this case. And also we see like there is a decreased gluconeogenesis. So there will be a normal or low glucose level because of that, and increased glycogenolysis. And also because of the chronic alcoholics also will contribute for this acidosis. And binge drinking weeks before symptoms. This is quite thing where they take a lot of high quantity of the alcohol. And also along with that, it's an usual talk that when the alcohol is consumed, there should be a proper food to be taken, and to could be because of neutralizing some of the alcoholic effects of this, but because of dehydration and starvation, and it may also cause vomiting and gastritis, where this again leads to the acidosis. So this is how the ketogenesis formations usually leads to. So as you know, like alcohol get converts into an intermediate called acetaldehyde, then convert to acetate, and the NADH and NAD ratios increases here because of this if, and decrease in the gluconeogenesis. And also there is a poor food intake. As I told, like food, if the food is not consumed after the alcohol intake, so there is a glycogenolysis increase. This also leads to ketogenesis. Also dehydrations. So there is an increased counter-regulatory hormones, as you know, like the water ADH. There is a decrease in the water, antidiuretic hormone increases, and also the changes in the electrolyte concentrations. It will have a lot of hormonal release impact happens. And also here there is an increase in glucagon and decrease in the insulin can occur. So all this can leads to the prominent the ketogenesis. And the complications of this ketogenesis is mainly the mental functions alterations. So any kind of, even whether it could be metabolic acidosis or any other changes in the electrolytes, especially changes in the pH. So CNS system is commonly altered. So there is an altered mental state.
CNS system is
So could be because of the change in the pH, and this the blood-brain barrier can become more leaky, and the toxic substance can enter into the CNS. That could be. Also, optimal breathing is there, where you see that more of sudden breathing, okay, because of deprived oxygen, and ketotic breathing. You can see the odor. The odor of the ketotic is causes fruity odor. Let's say ketone bodies usually causes fruity odor. So this is also one of the thing. And lab findings, you can find high anion gap acidosis, an increase in beta hydroxybutyrate and acetoacetate. So when this kind of the signs and symptoms and lab findings are observed, so only one other cause, as I told, the other cause in the similar conditions like metabolic acidosis. So you have to exclude this differential diagnosis to confirm whether it is ketoacidosis. So that's the another complication is hypoglycemia. So as like glucose level decreases in the blood. So usually say that the chronic street alcoholic found unresponsive. So you can see the people, most of them, they drink and sleep on the street. They are even not even aware like what's happening surrounding them. It's because of more of hypoglycemia, decrease in the glucose level. And also some symptoms like neuroglycopenic, which causes confusion, fatigue, seizure, loss of consciousness. And if not uh, corrected these symptoms appropriately on time, death also can occur.
Sorry.
Also the yes.
So if there is a chronic consumption of alcohol,
Mm.
that could be leading to a diabetes mellitus because of this hypoglycemia.
Yes. See, the problem here is when you see about the alcohol and the diabetes mellitus, there are a lot of the misconceptions are there. They talk like then mild alcoholic helps in the diabetes, but what happens is this is one of the most common. Another thing is if the person is diabetics and patients taking oral hypoglycemic, or this patient is on insulin. So one of the most common and very dangerous uh, adverse effect of oral hypoglycemic and insulin is hypoglycemia. Okay, so when even the alcohol is taken, then this also will contribute to hypoglycemia. So the chances of getting hypoglycemia is very higher in diabetic patients. The thing is that one thing. The another thing is, as you know, in diabetes, the glucose level in the blood vessels it's always, glucose is an irritant. Okay, so it's a very irritant, and it causes a lot of the surface that comes into contact with the glucose, it causes a lot of changes in that surface. So the glucose in the blood in the diabetes patients always cause the blood vessels to get more of thickened. So the lumen of the blood vessels reduces actually because of that. And even this alcohol also will have some kind of thickening of the blood vessels, because it's a profound vasodilatations. Always vasodilatations will leads to the loss of the elasticity of the blood vessels, and this is also the one other contributions. But as you know, like here, the alcohol reduce glucose level reduces after consumption alcohol. They say it is helpful in the controlling diabetes, but that's what the consumption should be very in ideal quantity. Much. Is that you? Did you get the answer or?
Yes, sir. Clear.
Yeah. And also the autonomic responses like palpitations, tremor, and sweating also is or quite commonly seen in because of hypoglycemia. The signs like pallor, diaphoresis, more of sweating, tachycardia, raised systolic blood pressure, and also any kind of the transient focal neurological signs are commonly seen. The next is water and electrolyte disorders. So this is quite often, but they say like all alcoholics are dehydrated. It's also false. But yes, there is an decrease in the changes in the water electrolyte disorders. But there is a mechanism in the body to combat any decrease in the water and electrolyte, like immediate release, increase in the urine volume can leads to followed by increase in the ADH, so antidiuretic hormone. So any loss of water and electrolytes because of urinations after the thing is can be combated by increase in the ADH. So it decreases the water and electrolyte eliminations. But it also depends on many things, that how the person has hydrated previously, and all those things. See, also hydration also depends on like diet, what food is taken, non-alcoholic fluids, what of type of drinks is taken. So you cannot say that all the alcoholics will get dehydrated, because that particular time how much other hydrations how he has done and all those things. And also in conditions like vomiting, so more of water and electrolyte loss, diarrhea also, or any infection. So in these conditions, there is a profound loss of water and electrolytes. And also there is a water intoxication and hyponatremia, decrease in the sodium can occur. This could be one of the most reason for getting the seizures or changes in the sensorium, the patients. Also central pontine myelinolysis. This is mainly the muscle dissolutions. The myelin sheath get this one, the nerve and the muscles where feet. Okay, so they also get the damage. So that's what the neurological and the muscular damage are quite common in alcoholic patients. And along with this, the other electrolyte abnormalities also can occur, like hypomagnesemia, phosphatemia, kalemia, and also calcemia. So you can see these all are hypo. So all there is a decrease in this, and very prominently you can see that the kalemia and the potassium and the calcium. Okay, so very quite sensitive to the heart muscles. So also there's chances of lot of involvement of the cardiac issues if there is a profound loss of potassium and calcium. And yeah, this is Wernicke-Korsakoff's syndromes. This is, you can see in the alcoholic patients, one of the most common is thiamine deficiency. That is the most common, and thiamine is helpful for any kind of the neurotransmitter, nerve impulses transmutations. So that's why thiamine deficiency impacts a lot of metabolic activities and also a lot of the nerve damages. So it's very seen highly in almost 12.5% in alcoholics. And the another worry about this syndrome is it's a major reversible cause, okay, of death. So in the very critical conditions, this is occurs. And also the mortality rate is very high if it is not treated, say like 10 to 20%. And also thiamine deficiency, as I told, and also the magnesium deficiency. So thiamine and magnesiums, they have concomitantly have influences on that. So decrease in the thiamine also leads to the decrease in the magnesium. You can see in the wards, thiamine and magnesiums concomitantly given in the alcoholic liver diseases patients. So the major clinical features of this is global confusions, ocular abnormalities, and ataxia. So where the nerve coordinations get usually affected. And this is the effect on art. So we have direct negative inotropic effect. So like it's decrease in the impulses, the sinoatrium node impulses generations and transmissions, and also vasodilatation. So because of vasodilatations, the blood return to the heart also it's decreased. So that is the thing. And also the pulse rate and is down there, and also QT prolongation occurs because there is a slow pumping of the heart. And supraventricular and ventricular arrhythmias are quite common. Uh, this is sometimes case like tachycardia is quite because of decrease in the vasodilatation, and even though there is a negative inotropic effect, but the impulses what there is already there, they keep pumping the increase the heart rate because the pulse rate decreases, the blood volume decreases. All these are as a compensated mechanism, heart starts to pump at faster rate. And also it's also called as holiday heart syndrome. So and also various degree of heart blocks can observe because of formation of clot and this one. And one another very important thing that occur here, because vasodilatation, like the blood movement in the blood vessels slows down because of vasodilatation. So when the vasodilatation blood slows down and the blood return to the heart is decreased, the blood, as you know, like the way pattern of blood flow in the blood vessel is like the plasma covers the outside and the cells runs middle of the blood vessel, this, and usually there is no contact with the blood cells, like especially the platelets, with the interior surface of the blood vessel. But when it is vasodilatation and the slowdown of blood, it causes the mixing of these thing, you are understanding, no? And and because of this, the platelet can adhere to the blood vessel. Okay, so and that may cause the formation of the clots there. So and because of this clot, there is also heart block. So it's a positive correlation between and sudden cardiac deaths also can occur because of this. And myopathy, alcoholic myopathy, as you know, like muscle issues very prominently occurs. It also takes off the muscle mass in the body. So acute muscle necrosis because of being drinkers causes, and also rhabdomyolysis. Okay. This is a dissolution of muscle can occur most cause, and also raised CKMM like creatine kinase, skeletal muscles things, and myoglobinuria is commonly seen. And acute because of this myoglobinuria and increase in creatine kinase, this one, the debris of this muscle where it is destroyed usually get eliminated through the kidney, but the debris, because of the muscle elevation goes to the kidney, there the debris can get caught into the glomerular filtrations, so the mesh. So that itself can cause the acute tubular necrosis. So, and also increase in urea and creatinine. There is a conservative management. You have to give a lot of fluids here to clear the debris, diuretics. And there is also which because of the urea, increase in urea toxicity. So you have to manage this and conservative. And GI effects are quite often in the thing. So it's also gastritis cause esophagitis and epigastric distress and GI bleeding. And malarious tears, this is one of the, again, the esophagus tearing can cause also ulcer, tearing of the esophagitis. Can, this is the thing which because of more irritant property of the alcohol. The acute hepatitis and pancreatitis also can be observed. The differential diagnosis mainly in acutely intoxicated patients, toxic, we have to see metabolic and any other infectious disease, neurologic, trauma, and miscellaneous. So in these patients, it has to be very, uh, uh, should be very carefully we have to handle these patients. And coming to the diagnosis of any intoxications, we have history. It's very important. What kind of alcohol consumed? What is the quantity? Also, what are the time course after consumptions? Also, what was the circumstances? Any eventual injuries appeared? These are all the history taking is very important. So you can understand, like calculate what going to be the intensity of the alcohol intoxication. So that is can be predicted by taking proper history. The another important is physical examinations where vital signs, nutritional status, hydration, the alcoholism related signs like capillary prominence, spider neve, and telangiectasias, pulmonary arrhythmia, and muscular atrophy. So this is, you can see that especially on the fingers, the subcutaneous skin, this one, and also observations by the muscular rigidity. All these observations can be done. The lab investigations also very important to confirm this. So one, as I told, like is blood alcohol concentrations. Earlier slides have shown that 0.02 to 0.40, okay, gram per deciliter from mild to the death. So the concentration of the alcohol in blood is directly related to its severe effect. So it's a very one of the most important. And the serum osmolality also increases because of the electrolyte disturbance, loss of the sodium, potassium, calcium has to be done. Blood urea, nitrogen, blood sugar, amylase, LFT, liver function test, arterial blood gases to know the saturations. So urine and blood ketones, ECG, chest X-ray. So CT8, anything kind of head trauma is suspected. These are the quite common and for any kind of alcohol intoxications it has to be done. Coming to the treatment, the treatment is one of the more supportive kind of treatment more than any kind of specific treatment. So airway assessment, one thing to check the ABG, arterial blood gas, and any kind of decrease in the oxygen saturations. So the oxygen has to be given this one. And also the breathing. So breathing rate usually, as I told, it will be decreased because of the inhibitory actions of the alcohol. So here they usually try to increase the breathing rate. Here they give more of any kind of the adrenaline, even for the circulations to improve the circulations. So sympathomimetic drugs usually are used where they cause vasodilatation, vasoconstrictions, which helps in the circulations and also increase in the breathing. And see the IV access. especially for giving the fluid and electrolytes to keep the dehydration also, as you told, and electrolyte disturbance also will be more. So quite commonly, the usually glucose also decreases. So the dextrose, ringer lactates, sodium chloride. So these are all the few IV fluids that usually will be given there. And also rise tube and also propped up positions to avoid aspiration. So because the patient will be more on subconscious level, and any kind of content patients taking or some kind of vomiting is happening. So the epiglottis stage, where we say like the closing of airway and the esophagus, that may not uh, happen. So that's why there is a chances of getting the esophagus content into the lungs. So to avoid this, the rise tube is better to give the filler. And also propped up positions is mainly lifting the head, keeping the pillows back, lifting the head like this, and even the back arm rest increases like this position. So these two things has to be done, because the reflex mechanisms in the alcoholic patients is very poor. So that's the thing. And also Foley's catheterizations can be done to got the urinations out this one. And also thiamine, as I told, 100 mg IM or IV stat dose has to be given. So one of the most prominent drugs, if it is for any kind of the alcoholic thing. Also mechanical ventilations if required, it has to be given. The patient is having very severe conditions. So this is the IV solutions, like 1 liter of 0.4%, 45% dextrose, as I told, normal saline, 2 gram magnesium sulfate, 1 mg, and also folate, and also 100 mg of thiamine. Okay. So 1 liter of 0.5% dextrose and normal saline, 2 gram of magnesium sulfate, and 1 mg of folate, 100 mg of thiamine. So these are the few immediate treatment for the ethanol poisoning. As I told, thiamine and magnesium together both get decreased, and along with this, antiemetic drugs to avoid the vomiting, and also sedatives, because the persons intoxicated persons, even though he becomes subconscious level, but in the severe conditions, agitations and violent patients, they become more. You can see that when in the wards, those kind of persons, they does not allow anything to be there near to him. He become more violent. He will be shouting. And what are the IV lines? It's put. He will try to remove that IV lines and show the agitation. So in such kind of patients, you can see that they usually do restrict the patient's movement by tying his legs or hands to the bed. And for these patients, the sedatives also can be given, like alprazolam, anything like which reduces its agitations and droperidol and haloperidol for kind of decreases his psychotic symptoms, and also physical restraints. So used, as I told, they tie to this one, used only in extreme. They tie the leg and this one. Some people will be more ferocious and becomes more aggressive. So during this time, physical restraints also can be done. The mechanical ventilation and intensive care, if it is very severe condition, patient is in coma, so it has to be immediately addressed. And the other drug we use is the metadoxine, which is one of the, you can say that like an antidote, not specifically an antidote, but it's one of the specific drug in the treatment of acute alcohol intoxications. As you know, the body is deprived of the oxygen, the energy molecule like ATP, or usually uh, decreased because of no metabolisms, thiamine, magnesium, decrease. So the whole metabolic activity in the body is decreased. So to make present when the metabolic activity decreases, the cells and tissues does not, it will be deprived of energy. So the one of the most common first thing we have to provide the energy to these things. So this metadoxin will do that. So it facilitates ATP synthesis, and also it's prevent decrease in ATP both in brain and liver. So this is, as you know, like more alcohol consumption, liver is one of the more stressed organ. And apart from that, because liver failure also leads to the toxic substance which makes the blood brain barrier loosen, and because of this most of the toxic substance will enter into the brain, and brain encephalopathy can occur. So these two things, two major organs can affect. So even this drug can provide the ATP to these two major organs. So it's usually given is IV injections, single dose at 900 mg. Okay, so this also will decrease the half-life of ethanol. So we have seen the half-life of ethanol is 2 to 6 hours. So it's the half-life is totally decreased. So as you know, like the half-life is totally decreased, the ethanol is converted to carbon dioxide and water is very quick. So if the effect of ethanol is almost reducing because it's converting to carbon dioxide and water. So the complications due to alcohol will be can be managed. And the medial time of recovery is usually around 1 hour. You can see that even though the ethanol half-life is 2 to 6 hours, but after giving these drugs, the recovery itself is 1 hour. So it's almost the half-life of ethanol is reduced. So now coming to the methanol poisoning. As you know, the methanol is toxic to human being. There is no used in the beverages because of its highly toxic nature. But this methanol is even in use like few solvent, antifreeze, and paint remover. And this the content of this methanol in these substances also can leads to the making of the thing, exposed to the human being. The absorption is, you can see that methyl alcohol toxications through oral ingestion, many times ingestion intentionally or accidentally. Because of suicide in nature, they may take the nail polisher, also some kind of solvents which is used for painting or some other kind of thing. So half-life is, you can see that it's a very quick, 5 minutes only. Okay, it's not like more of ethanol where it's 2 to 6 hours of life. And peak absorptions occurring between 30 to 60 minutes. And the other routes of absorption are through intact skin or inhalation. Even it's more of volatile, especially in the solvents you use. It's used as more of inhalations, so it can cause the entry into the body. Also, there is a rapid distributions results in peak plasma concentration within 30 to 60 minutes. Metabolism, you can see that the ethanol and same pathways. There is also alcohol reagenation is convert. But one particular different is there in the ethanol, you can see the acetaldehyde is formed. Here it's formaldehyde. And there it's acetate is formed. Here is the formic acid. And lastly, it also get converted into carbon dioxide and water, which is quite usually same in the ethanol metabolism. The clinical features more, you can say, inebriated, but lack of euphoria. It's not seen like more of the ethanol activity where more of euphoric is there. And 40 minutes to 72 hours of latent period usually is seen. And also the dose is 60 to 240 ml. It's quite high also, where the dose of this is commonly causes it. And signs and symptoms are mainly limited to CNS, eye, and GI tract. it's not more of like liver or where the ethanol is more commonly, I think. Vertigo, lightheadedness, dyspnea, agitations, nausea, vomiting, diarrhea, also abdominal pain, especially the acute pancreatitis, even though not seen in the ethanol toxicity, in this methanol toxicity, the pancreatitis is was commonly seen. Also, there is a blurred vision, photophobia, and decrease in the visual axis. So you can see all these are very limited to the CNS, eye, and GI tract, and not much involved in the liver. And also blurred visions, mainly relatively clear sensorium. This is one of the first sign that is seen in the methanol toxicity. And also absence of the symptoms and clear sensorium not be usually does not rule out serious toxicity, but still the blurred vision has to be considered as one of the important first sign in the methanol toxicity. Also, co-ingestion of ethanol typically delays symptoms beyond 24 hours. Also, bradycardia, blindness, seizures, prolonged coma, shock, persistent acidosis and anuria are serious prognostic signs. If it is not controlled, these are all could be fatal later on stages. So physical examinations, eye examinations, constrictions, one of the most common thing. And also pupils will not get dilated. You can see that if you common human eyes, if you put a torch, okay, so get dilated. Also there will be a movement, even if you move, get moved. But here in the methanol toxicity, even if you put a torch and just try to move over the eye, the dilated will get, the pupils will get dilated, more open time, and it will not move for the reflexes, the movement. It will be fixed. So that's also one of the thing which we can examine during the methanol toxicity. And retinal edema and hyperemia of disc and opisthotonus. So it's also and more of the eye acuity, mainly white patches kind of things is most of seen that. And the respiratory failure and arrest is the main cause of death. So decrease in the rare respirations, like any kind of thing, that could be the more reason for the death of this methanol. And lab finding, it's same like an ethanol kind of things, like high anion gap is seen, ketoacidosis, metabolic acidosis, but not seen in ethanol poisoning, but in the methanol poisoning, metabolic acidosis is highly seen. And high osmolar gap, again the electrolytes disturbances. So all this will suggest the methanol toxicity. The routine lab findings will be again serum methanol concentrations, electrolytes including calcium, serum BUN, serum creatinine, CBC, urine, routine microscopy confirmed. And also liver enzyme like HOT and HGPT and amylase serum and also arterial blood gas. So it's almost similar like ethanol toxicity. The same lab findings are done. And also the imaging studies is done where bilateral necrosis of putamen, especially in kind of the chest x-rays they do it. In radiographic find very severe methanol toxicity is seen, any kind of damages. And also there is a marked cerebral edema accumulation. And also there is occipital lesions in cerebral cortex on repeat of MRI after 1 month, which also shows that visual impairment is permanent. So management of this, there is a lot of criteria which talks about, and one of same like metatoxin which we give for the ethanol poisoning. For the methanol poisoning, it's mainly with the ethanol or again fomeprazole. So ethanol is also counteract the action of the methanol. Also there is another drug, fomepizole. That's the thing. So it's any kind of plasma methanol concentration more than 20 mg per dl or 200 mg per liter, or any kind of history of ingesting toxic amounts of methanol or osmolar gap, or any history of following criteria like arterial pH is less than 7.3, serum bicarbonate is less than 20 milliequivalents per liter, or osmolar gap is more than 10 milliosmolar per kg of water. So if these are the criteria, if it is there, then there is an treatment has to be given with ethanol or also fomepizole. And this is the flow chart. It's quite very big flow chart. There is a lot of things which you can see here. I'll just summarize it in the thing. So it's a suspected or confirmed methanol poisoning. So you can see that does patient meet criteria in table 2. The previously which I showed, the table 2, arterial blood gas, all those things. If no, you have to reconsider diagnosis, and again you have to check it. But if it is yes, then we have to go for supportive care, administer folic acid or folinic, that is leucovorin. Just we have to check the pH. If the pH is less than 7.3, then no, bicarbonate not necessary. pH is less than yes, then administer bicarbonate to correct, because it will be more of acidosis. It bring the pH to above 7 point. And also in the supportive care, you can also give fomepizole available. If it is no, then you have to administer ethanol as per table 3, which as I told there. But if it is yes, in the administer of 15 mg per kg fomepizole. So it can be given ethanol or fomepizole as I told earlier. But if the pH is less than 7.2 or vital signs or any deteriorating vital signs, renal failure, significant electrolytes or anything it is there, then if it has to be gone for hemodialysis also. But if you know, then you can give fomepizole. Whether it is treated, yes, then maintain dose 10 mg per kg every 12 hours for doses. If it is no, then again administer ethanol. So again, ethanol, if you administer also in the concentration of 1 to 2 hours, and adjust infusion rate, achieve target of 100 to 150 mg per dl. Then continue until serum methanol concentration is less than 20 mg per dl. So that's the target methanol to come out of the danger way. And here, if it is yes, hemodialysis, you can go for fomepizole treated. No, then administer ethanol as per that, and monitor serum. It's the same kind of thing, and just see the methanol concentration is less than 20 mg per liter. If fomepizole is treated yes, then we can treat according to that same table thing, and which is there, methanol concentrations less than 20 mg per liter. So this is the overall the flow chart for the treating management of the methanol poisoning. And also, if the patient is on hemodialysis, the fomepizole dose has to be modified. So the beginning of dialysis less than 6 hours since last dose. So it should not be administered dose again. If it is more than 6 hours, you have to give the next dose. But during the hemodialysis, every 4 hours, if the dosing at the time dialysis is completed in less than 1 hour, no additional dose. But if it is 1 to 3 hours, you have to administer 50% of next dose. If it is more than 3 hours, the next the scheduled dose, we have to give full dose. So the maintaining dose of dialysis, you have to administer within 12 hours after last dose. Then also aggressive treatment of acidosis by sodium bicarbonate can be given. The ethanol also is one of the most common thing in the methanol poisoning. So achieve blood alcohol concentration of under 200 mg per 100 ml. And loading is 0.8 gram per kg of 5 to 10% ethanol, followed by 130 kg per hour, or oral loading if no IV preparation is there. If dialysis is there, 250 to 350 mg per kg per hour of ethanol has to be administered. Folic acid 30 mg IV every 4 hours. Leucovorin is folinic acid 1 to 2 mg per kg per IV. And fomepizole 15 to 20 mg per kg we are stored. And hemodialysis also can be done, not hemoperfusion. The dialysis is important thing. And what is the criteria to start the dialysis in such kind of patients is like methanol is 20 to 50 mg per 100 ml, and acidosis not response even if you give bicarbonate, sodium bicarbonate, where pH is less than 7.3, still bicarbonate is given, but the pH is not increased. So during that time, acidosis. And
Hello, Luai.
yeah, you're there, right?
Your habit.
Yeah,
No, sir.
Yes, sir.
yeah. I will share it again. I think I will disconnect.
Yeah, okay.
Okay, I will just finish in another 5 or 10 minutes.
Okay, sir.
Okay, and also the format levels is more than 20 mg per 100 ml. You can see, right?
So there is no format.
Small format.
There is no format. Yeah. Okay.
Okay. So visual impairment and also renal impairment is then this time this situation we have to put the patient on hemodialysis. And the dialysis still methanol level is coming to almost 0 mg per 100 ml, and also acidosis clears. The dialysis has to be continued very rigorously. Lastly, the withdrawal syndrome. So even though we are does not have much kind of withdrawal syndrome here because it's a poisoning intoxications, it's an acute stage. But because the patient is stopped even in the treatment for longer time, the alcohol intake. So the withdrawal syndrome also can occur in such kind of patients. So this results from ethanol intake reduction, not because of complete withdrawal also. So how this withdrawal symptoms usually, as you know, like patients from last drink is about 5 days, and but can last up to 14 days. Okay, the persons who, even if you see like few hours the alcohol intake is reduced, their hands will get shivered and all those things. And this one, okay, do not treat alcohol withdrawal with more alcohol. Should not take that. That's the worst things. And the symptoms is minor withdrawal symptoms like insomnia or CNS symptoms, with their headache, diaphoresis, palpitations, GA upset. So it's seen in 6 to 12 hours. And also hallucinations like visual, auditory, or tactile hallucinations are seen in 12 to 24 hours. And in 24 to 48 hours, some seizures can occur in patients, people who are not taken with this alcohol. And also in 48 to 72 hours, some delirium tremens, hallucinations, disorientation, tachycardia. It's one of the most common, again, few prominent symptoms can occur at as you see that as the timeline, there is more gap, the severity of symptoms also increases. And the 10 most common specific symptoms for alcohol withdrawal is like depression, and most specific like whole body shaking. Most common symptoms like depression, anxiety, irritability, tiredness, craving, restlessness, insomnia, confusion, sweating, and weakness. But specifically like whole body shaking, hand finger shaking, also facial tremulousness, is the day, panic, guilt, nausea, visual hallucinations, weakness, and also the depressions. So these are all the few very specific symptoms that we see now. And signs and symptoms like in uncomplicated withdrawal features, same like autonomic hyperactivity, we have seen that. Along with this, fever also will be there. And GI symptoms were very commonly. And cognitive and perceptual changes, same like poor concentration, anxiety, psychomotor agitations, disturbed sleep, and vivid dreams. In severe withdrawal complications, autonomic hyperactivity is very high because of dehydration and electrolyte. And also cognitive and perceptual changes also will be high, like seizures, hallucinations, and delirium. Can you see that? There is also criteria which you can classify into alcohol withdrawal. So like cessation for alcohol has been heavy and prolonged for 2 or more following, if it occurs in several hours to few days, then you can say, as in like autonomic hyperactive, increased hand tremor, insomnia. So this is all the criteria. These all the things is again repeating. I will not go into detail into this. You can just go read about this criteria. And also the C part, like what all the criteria symptoms seen in criteria, and B is clinically significant distress and even impairment in social occupational. It's affecting its social life and occupational life, and also any kind of general medicines if it is caused, then also it is. And there is also a clinical institute of this scale is there, assessment of alcoholic withdrawal scale, which scores different scores. So like if it is less than 9, it's mild, 9 to 15 moderate, and more than 15 it is severe withdrawal. So based on this, the alcohol withdrawal is severity is usually classified, and this is how the assessment is there on different things, and there is a scoring system like nausea, vomiting, do you feel sick, or tremor, ask patients to extend arms and spread, and there is if it is anything, then they give the points marks and just totally calculate later. And paroxysmal sweats and anxiety, and other thing like agitations, auditory disturbances, and tactile disturbances. So in this they give the each points. So if it is seeing that one, the thing which is qualifies what is the clinical manifestation in that patient. Based on that, you have to keep the points there and totally at the end and see how much it comes. And visual disturbance, headache, orientation, and clouding of sensorium. I'll not go detail into this. This is also a scale which is lead for assessment of. And this is the last slide. The immediate management of alcohol withdrawal. Okay, so patient has to get hospitalized. That is the thing. And because the patient will be more of agitated, benzodiazepines are quite commonly used. Give at a lower dose like diazepam or chlordiazepoxide, and also chlormethazole can be prescribed for any admission patients. And delirium tremens first should be treated with benzodiazepines like clorazepam, reduce. Also with alloperidol or olanzapine, which can be reduced. And the symptoms should be observed and see the effectiveness of this. And in the long term, I'm just not included in this. Disulfiram also can be added, but there is also a quite efficacy thing because long term only it works, not on the hospital setups or any in the acute setups. Okay, so that's all about this. Any questions you have?
Yes, sir. What question is there? I did not ask you before. So while we in methanol toxicity, we are using hemodialysis, but not hemoperfusion.
See, hemodialysis is more accurate. Hemoperfusion, the efficacy is not so. This one, the one thing you have to keep that the hemoperfusions try to remove some kind of the content from the cells or tissues. Hemodialysis mainly more in the blood, it will get reduces concentration. So blood concentration reduction is very, very important. As we see all our the severity of the alcohol toxicity is mainly on blood concentration. So it's a more efficacious, quick,
Got it.
and reduces the blood concentration. Is it?
Okay, sir.
Okay. Any other questions from others?
Yeah, got it.
Okay, I'll just share this PPT, and this video also will be available on KCP online this, and we'll share you that link also.
Sure.
And I need the attendance anyhow. I have the attendance here. But also Delvin is there? No.
Yes, sir.
You take the attendance also, which is there. This manual
Okay,
attendance.
okay.
Okay.
Okay,
So
sir.
we'll see that. Have a good day. I think no one has, or everyone are safe from Corona, right?
Yes, sir.
Huh?
Yeah.
Yes, sir.
Okay. I think next week also maybe leave. We are still officially not declared. could be they do it. So we'll see like
Okay.
next also some kind of classes like this. We'll tell you. What time is the preferable time? Morning is good.
9 or 10.
Time.
To morning. 10.
9 or 10.
Morning is better, sir. 8.
Because we can finish
Yeah,
this
sir.
and can continue with your work, no?
10
After
o'clock is better, sir.
huh?
Clock is fine.
Yeah. Okay, we'll let you know the next class. Thank you. Bye.
Okay, sir. Thank you, sir.
Bye.
Thank you, sir.
Thank you, sir.
Thank you.